Yes? So what you're going to say to this patient, to the exam answer, is that this is a 19-year-old. He has got a Bankart injury. Bankart injury will not heal on its own. There is a high chance that this will redislocate again. So when time is appropriate, patient is stable, and there is no contraindication, I will plan a Bankart repair for this patient. Okay? That's what you're going to say in the exam.
So is it necessary without keeping in view the occupation of the patient to go for surgery in every patient with the Bankart repair? Because almost in 2/3 of cases there is a Bankart lesion, sir.
Yes, so if there is a Bankart lesion, person has come with a dislocation, you know there is a high chance that they will dislocate again. You can give them at least 6 months to plan surgery or leave them alone. You leave them physio. If they do not dislocate again, then you can leave them alone. But if they dislocate or they have symptoms of instability, then you have to intervene.
Okay,
So it depends on what the symptoms are.
Fine, sir.
Okay, so now if the patient, if this is a 19-year-old, then he has got an 81% chance that he's going to dislocate again. However, he also has a 19% chance that he won't dislocate again. It's low, but he has a chance. So what you do is you leave them with physio and you see how they respond. If he cannot play any sports, he can't do his job, or he has a recurrence of dislocation, then obviously this person needs help. And the answer to the exam question is that I will take this patient and organize appropriate physio. If the patient has recurrent symptoms or instability, I will plan a procedure for a Bankart repair. Now, you can tell the examiner that it can be done either open or arthroscopically. The current trend is to do it arthroscopically, but if you can't do it arthroscopically, then you can't leave it alone. You either refer it to somebody who can do it arthroscopically, or you do an open Bankart repair, because open Bankart repair is still a gold standard. Yes?
Okay.
Yes, no?
Yes, sir.
Okay. So the next question is now that you have seen this person and he is now 2 years down the line. Okay. So he has now had at least 10 dislocations since he last saw you. How are you going to investigate this person now?
We'll go with an MRI.
So you don't ever do MRI scan on its own in instability. You either do an MR arthrogram or you do a CT scan. If it's an acute phenomena, you will do an MR arthrogram. If it's not an acute phenomena, then you will do a CT scan. Okay, the CT scan will tell you two things. What are we looking for in a CT scan?
Two things, either whether it's the humerus, like an L-sax, or maybe the glenoid, like a bony Bankart or something.
Okay, so what is it called? There is a name for this.
Macklin lesion, sir.
Is what, sorry?
Macklin lesion, sir.
I've never heard of that name. You're probably right. But what we call it in this part of the world is it's a bipolar injury. Okay, both sides of the joint are injured.
Fine, sir. Yes, sir.
Okay, so in a bipolar injury, how do you manage a bipolar injury?
It would depend on the size. We'll measure the sizes, how much of, if it is in the glenoid, we need to measure the defect size. Okay. And also whether if it's the humerus side. So we have to know how much percentage is lost, if there is any loss in the humerus.
So is there a name for this thing that you do? What do you call these things?
I'm sorry, I forgot the name.
It's an on-track, off-track lesion, yes?
On-track, off-track, sorry.
Very good, yeah. And how much of the glenoid should be, how much of the humerus should be missing before you can do something with it, and how much of the glenoid should be missing?
40% of the humerus, and we are talking about, I forgot the percentage on the glenoid.
So 25% of a Hill-Sachs lesion, or more than 25%, is concerning, okay? So the first option is that you have assessed this person. He has got no bony Bankart, he has got no glenoid dysfunction, and he also has got no humeral involvement, i.e. no Hill-Sachs lesion. For this person, you will do a Bankart repair, okay? So if he has got an on-track lesion, okay, which means that the humeral head is contained with the glenoid, you can still do a Bankart repair for him. However, if he's got an off-track lesion or he's got more than 25% defect with a Hill-Sachs lesion, then you will do what is called a latter J procedure. Okay?
Okay, sir.
Sometimes you can do a combination of latter J and Brem-Prasad, which is putting soft tissue at the back of the defect in the humeral head. If you've got a big, huge bony defect and you're concerned that the latter J might not repair for you. So anything that's soft tissue only is a soft tissue repair, which is a Bankart repair. Anything that has got a soft tissue and a bony region, but less than 25% and is on track, you will do again a soft tissue procedure. However, if it is more than 25% and is off track, you will do a latter J procedure for them. Okay?
Okay, sir.
So how would you assess somebody who comes to you for the first time with a dislocation that is happening, say 15, 20 times already? It is now dislocated first time about, say, 10 years ago, and he's now come with everything okay, but what are you going to do in the history and examination to make you to come to a decision what you want to do for this person? So we've just discussed a traumatic one, isn't it? So the other one is that somebody has come and dislocated. So what are the important types of instability that you're looking for?
We'll assess the patient. We'll ask him regarding his history, how many times has he dislocated, and
I've just told you 20. So you're repeating what I just said. I said 20 times.
And then we would do a Beighton score to address
so the first thing you have to ask him is, what is the age of his first dislocation? Okay. The second thing you're going to ask him is, what was he doing when he dislocated? If it was a trivial injury or it was a major traumatic episode. So what's the difference? If it was a trivial injury and somebody dislocated the first time, what does that tell you?
That means there is laxity.
Yes, so he has got a laxity, and to assess laxity, you have what we call as the Beaton's criteria, isn't it? There are 9 elements to the Beaton's criteria, and you're looking at the Beaton's index. Okay?
The idea would be to differentiate between TUBS and Embry. Traumatic.
How do we differentiate?
With the laxity scoring, with the history, if there's a trivial trauma or if it's a major trauma.
So it's very easy. What does TUBS actually stand for?
Traumatic.
Unidirectional.
Yeah. So traumatic, unidirectional, TUB. What does B stand for?
Bankart, sir.
And what does S stand for?
S for surgery, sir.
Yes. So in traumatic, when there is only one direction, one shoulder that's in trouble, and you have a clear history of trauma, then it is a traumatic element to it. The second part is called Embry, which is atraumatic, multidirectional, bilateral, and you have to do rehab for them. Okay. And you can sometimes do an inferior slide. However, there is a thing called the Stanmore's triad. What is the Stanmore's triad?
Polar type 1, type 2, type 3, sir.
Sorry?
Type 1 traumatic. Sir, in this triangle, there are 3 types of this multi-directional instability. Polar type 1, that is traumatic one. Polar type 2, that is due to ligamentous laxity, and polar type 3, which is associated with the soft tissue abnormalities like Ehlers-Danlos syndrome.
The other one is people who just dislocate their habitual dislocations, dislocated. Okay.
Yes, sir. Habitual is also come in polar type.
So this is the Stanmore's triad. Okay. So one is
yes, sir.
So one has got a traumatic element, right? These are patients here. The other ones are the atraumatic, which are multidirectional, and then these are polar type, which are patients who are trying to dislocate their shoulders themselves. Okay, so there are 3 types. However, it is not a triangle, but it's 3 circles. Okay, and the circles overlap. So the worst part is somebody who is atraumatic, has had trauma, and wants to dislocate his shoulder himself. Those are the difficult ones. The simple ones are the traumatic ones who only have a soft tissue problem that you can repair. So if the cervicals overlap, there's a bit in the middle, which is a bit that is more difficult. Okay, so good. So we've done instability, we've done how to manage it. So now you've taken a history. You know that it is this is a traumatic episode, it is recurring for loads of time. The management again goes back to the same thing, is you need to quantify the problem, how much of bone and soft tissue is involved. If you've got more than 25% of a Hill-Sachs lesion and you have got an off-track lesion, then you will do a lateral J procedure. If you've got a big defect, you do a lateral J with rim massage. Otherwise, all these patients can be treated with soft tissue repairs. Happy?
Yes, sir. Fine, sir.
Okay, so I want to show you something else now. What am I showing you? I am showing you. Okay, so who wants to go? This is the brachial plexus patient that we want to discuss, yeah?
Fine, sir.
Yes, sir.
Okay, so who wants to describe this? Nobody wants to go? You've had a talk recently, not so long ago.
And it's a picture of an adult gentleman with from base of the neck till umbilicus. I can appreciate there's a scar mark on the left shoulder and the wasting of the muscle around the shoulder joint.
Okay, so the most important thing when you see a photograph like this is you have to look at the posture of the hand. So there are three types of postures you're looking. You're looking for a flail hand, which means it's a total involvement of the brachial plexus. You look for the Klumpke or the Erb's palsy. This person has got an internal rotation, okay, and an abduction type of injury. Where do you think the problem is here?
Upper trunk, sir.
Upper trunk.
So what is that called?
The Klumpke's paralysis.
So that's
Erb's palsy, sorry. Erb's palsy, sir.
Okay. So what would that show? That would be like a waiter's tip deformity, isn't it?
Yes, sir.
So why is this different from a waiter's tip deformity?
There has been some surgical intervention.
Yes, there has been a surgical intervention, so they have done it, but this looks like an Erb's palsy that has surgical correction done, isn't it? Okay. Because it doesn't look like there's an ulnar nerve involvement. It doesn't look like a totally flail arm, so it doesn't look like something like the upper trunk where there has got a surgical correction done or some sort of correction done. Before we go into this, what are the three important functions that the arm should have after you do or attempt to do a brachial plexus repair?
Hip, shoulder abduction and sensation along the medial side of the forearm, sir.
Sorry? Three things. I said three things.
Sir, elbow flexion.
Yes, sir. Flexion of elbow flexion, sir. Shoulder abduction and sensation along the medial sir forearm.
There's three important things. Flexion comes first, abduction is second, and then sensation is third. These are the three things that you have to achieve to have a successful outcome of a brachial plexus injury. Okay? So do you know how to localize the brachial plexus injury, or do you know what types are available?
Yes, sir. It can be localized with a systematic approach, starting proximally and going distally, sir. First is to localize the lesion, whether it's from the root and if it's from the upper root or the lower roots, and then is the trunk, and there's the course or the.
Very good. So first thing, we want to make sure that this is a pre-ganglionic or a post-ganglionic injury, yeah? Which means roots. So how do you know that this is a pre-ganglionic or a post-ganglionic? What test can you do?
Sir, it starts with the history, sir. Patient present with the weakness in the evening, sir, and there is signs of the on inspection. There are signs of Arnold syndrome, sir, and there is weakness of the serratus anterior, sir, and winging of scapula, sir.
Is what? So you will have what is called a Horner syndrome. The eyelid will be small, and you will have loss of sweating, and you will have a sunken eye appearance of the eye. Yes, these are all pre-ganglionic syndromes. Okay, so if you look at this picture, you can see that the pupil is dilated on one side, which is a T1 evidence of involvement. Yeah. The second thing you can see is the winging of the scapula, which is because the rhomboids and the serratus anterior are weak. These are all features of pre-ganglionic injuries. Okay.
Yes, sir. Yes, sir.
Okay. And this is an examination which you all know how to check rhomboids and serratus. Okay. So now once you know this is post-ganglionic, you want to know whether it is coming from what now? The next thing is you have to do.
Next is to see the trunk level, sir.
So there's only one structure that comes from the trunks, and what is that?
Supraspinatus, sir.
What does that supply?
Suprascapular nerve supplies the abductor and the external rotator of the shoulder, sir.
So the suprascapular nerve supplies the supraspinatus and infraspinatus.
Yes, sir.
Okay, so you will assess the supraspinatus and infraspinatus. Okay, there's a heavy diaphragm also available in these preganglionic ones. Yeah, okay. So the suprascapular nerve, you need to assess supraspinatus and infraspinatus. Okay.
Yes, sir.
The supraspinatus is in 30 degrees of the line of the scapula. If you can lift them up, the supraspinatus is palpable. And infraspinatus is the extension rotation lag sign, which tells you that the infraspinatus is gone. So you know it's not a root, you know it's not a trunk, because if these muscles are working, then it's not a trunk. So then you have chords, yes?
First, we will assess the posterior cord.
Okay, so what is coming from the posterior cord?
Subscapular, thoracodorsal, axially and radial.
Okay, so you need to assess whether it is medial cord, lateral cord, or posterior cord. So the pectoralis major will tell you whether it's a medial or lateral cord injury by assessing the pec major, because the pec major has got a lateral pectoral nerve and a medial pectoral nerve coming from the medial and lateral cord, yeah?
Yes, sir.
Okay, so the medial pectoral nerve supplies what part of the pec major?
So it supplies the
Sternal head.
External part.
Yes.
It supplies the external.
External part of the pec major, okay? And the clavicular part is supplied with the lateral cord. So if you assess the brachial plexus and you can see the pec major, and if the pec major that is coming from the sternal part is not working, then it's a medial injury. If it is working but the clavicular part is not working, it's a lateral injury. And what do you assess for the posterior cord? What will you do?
Posterior cord, deltoid power and radial nerve for the arm.
So it's the subscapularis. Posterior cord, to assess the posterior cord is the subscapularis muscle, which is the belly press sign. It's like assessing your rotator cuff. If you're assessing your rotator cuff, you will know that the lateral, medial, or posterior cord is working or not. Okay? So yes, subscap is the posterior cord. You know the belly press or the
bus lift off.
Yeah, so to assess the posterior cord, you do subscap. To assess the medial and lateral cord, you will do the pec major, whether it is the sternal part or the clavicle part is not working. So now we know the roots. We know there is only one that comes from the one nerve that comes from the the supraspinatus and the suprascapular nerve comes from what? Sorry.
Superior trunk, sir.
Yes, so one from the trunk. We know it's not a root. We know it's not a trunk. We know how to look at the medial, lateral, and posterior cord. Now you come to individual branches of the nerve, and which are?
Radial nerve, ulnar nerve, median nerve.
Very good.
Terminal branches, sir.
So how would you know that the lateral ulnar nerve, so the ulnar nerve is working, or the radial nerve is working, or the median nerve is working? How would you assess them?
Sir, by sensory and by motor function, sir.
Okay, so tell me one test that will give you the median nerve, one test that will give you the radial nerve, and one test that will give you the ulnar nerve.
Radial
so
nerve,
one test for the median nerve is to make an Uke sign, and for the radial nerve we make the big thumb to abduct to see the abductors, abductor pollicis longus, and for the ulnar nerve it is the format sign.
Abduction, adduction of the fingers.
So interosseous and abduction, adduction fingers. Okay, so
exactly.
Can we revise? Can one of you revise me now? If somebody gives you a brachial plexus patient to assess, first thing is you look for scars. Okay. The second thing is you look for posture, which position the hand is. If it's totally flailed, then everything's not working. If it is,
Yes, sir.
if it is abducted and internally rotated, then it's the superior part, or the what is called the Erb's palsy. If it is in a different direction, which means the hand is not working when everything else is working, then it means it's a clunkies type of problem. Okay. Now, if it doesn't fit into pattern and there's scars in there, that means somebody has either renovated it or does some surgical procedures to make it better. So to assess individually where the problem is from the brachial plexus, you will want to know whether it's a pre-ganglionic or a post-ganglionic. So you will look at the rhomboids, you will look at the Horner's sign, and you would look at the hemidiaphragm. This will tell you whether it's coming pre-ganglionic or post-ganglionic. When it goes
there's a question, sir, regarding Tinel sign, sir, which is used to assess the recovery, sir. Sir, is it present in the pre-ganglionic or post-ganglionic, sir? I think it's post-ganglionic, sir.
The Tinel sign.
Yes, sir.
The Tinel sign in pre-ganglionic will not be present at all. Tinel sign, it means that there is recovery happening. Where do you think the recovery will be happening? When the nerve has got some sort of attachment and it's moving on and it's not a complete injury. Now, pre-ganglionic will be a complete injury and that does not recover at all.
Fine, sir.
So a Tinel sign is a migrating Tinel is a sign of recovery. Okay, so now we know from the brachial axis it's not pre-ganglionic, it's post-ganglionic. In post-ganglionic, we want to know what the level is. Now, if the supraspinatus and infraspinatus is gone, we know that it is coming from that particular level. And if it crosses that level, we want to know whether it's lateral, medial, or posterior cord. Now, we need to look at the pec major, and we also need to look at the subscap. That will tell us which cord is involved. And then individual nerve will be easy to assess. You can look at the finger lag sign. You can look at the weakness of the interosseous, and you can also look at the thumb for assessment of the different individual nerves. Everybody clear so far with the brachial plexus assessment? Yes.
Reflexes, sir.
Yeah, but the thing is that reflexes are local things. And first of all, you need to individualize your nerve. Now, you can have 100,000 tests to do, but in the exam, you don't have 100,000 minutes to do it. So if somebody shows you a case and you can very quickly tell the examiner that this is where the lesion is localized, isn't that better than rather than doing everything? So what I'm telling you is within 2 minutes, you will tell the examiner where the lesion is.
Fine, sir.
Otherwise, there's loads of tests you can do for each and every segment, root, nerve, plexus, and examination, which you all know anyway, like I said. But I don't want you, or no, the examiner wants you to tell you everything. He wants to know where the lesion is. It's quick and simple. This is what you do in the clinic also, isn't it? You know where the lesion is. So to know where the lesion is, you have to decide whether it's a pre or post-ganglionic. If post-ganglionic, what level it is, then you can say very easily, this is what it is. Okay, so what is another test you have to do, which will not tell you the localization of the brachial plexus, but you want to do it? What is the other test then?
Transfer, sir.
So which test is that? What are you going to do?
Shrugging of the shoulders, sir, for the
spinal accessory. Yeah?
Yes, a spinal accessory nerve. Yes, sir.
Yeah, so you use that nerve to transfer. What other nerve can you use for transfer?
From the opposite side, sir, the intercostal nerve, sir.
You can't do that. What else?
Phrenic nerve.
What, sorry?
Phrenic.
So I can't hear you, sorry.
Sir, phrenic nerve, sir.
Yes, you can do that. You can do that. Okay. So
C6 from opposite side.
You have to make sure that what is available, and you also need to understand is how much of a distance it has to carry, and you must also understand whatever you transfer will lose its function. You must also remember that whatever you transfer will improve by 1 grade, whatever you're trying to achieve.
Fine, sir.
What are we trying to achieve?
Elbow flexion, shoulder abduction.
First thing we want to do is elbow flexion.
Yes, sir.
The second thing we want to do is abduction of the shoulder. And the third thing we want to do is sensation around the inner part of your chest. So how are we going to improve flexion of the elbow?
Assess what is available for transfer.
So what flexes the elbow?
Musculocutaneous nerve supplies the
what are you going to
brachial.
do to the you can add on to the the accessory nerve and graft it into the musculocutaneous to fire it. Yes?
So we can do an OBERLIN transfer in which ulnar nerve is transferred to the musculocutaneous nerve for the
You
elbow
can do
flexion.
that also. Okay.
And another option is Strandler flexoroplasty.
Go and describe it.
So another option is Strandler flexoroplasty.
Yeah, what is that?
Which is also done previously.
So what is that? You cannot say something and not know what it is.
So it's a flexor origin transfer to the humerus.
Yes, okay. So the
common
way to get function is to get nerve grafting, neurotization transfers, muscle transfers. Then you have to neuralize the scar to make it better and arthrodesis the joint to get the function. You can do an arthrodesis of the shoulder joint in abduction, and then you have flexion. Then you will have your hand going to your mouth. You'll be able to feed yourself, correct? What's the role of amputation in brachial plexus injuries?
Sir, flail limb, sir, and no loss of vascularity, sir.
Insensate hand.
So when is it that you cannot do an amputation? What is the one contraindication in doing amputation?
So when the trophic changes are being developing in the limb.
Now, the indication for doing an amputation is when it's a flail limb and it's a heavy limb and it is causing a nuisance. What is one contraindication of doing an amputation in a brachial plexus injury?
Functional hand.
So if you have functional hand, why would you want to do an amputation?
Yeah, it's a contraindication.
I know, but it's, you can't say that you can't drive a car just because you don't know how to drive a car, isn't it? So the contraindication for amputation is pain. You cannot do an amputation for pain. Pain relief is never going to go away in amputation. Okay, so that's the one contraindication for amputation in brachial plexus injury is when you have pain.
Sir, I got one question.
Okay.
Sir, when we will decide whether we'll go for any surgical intervention, when we'll decide?
Okay, so
or
surgical intervention, there are 2 or 3 indications that you have to do them early. 1, it's an open injury. You have to do a vessel or something nearby. The nerve is in the way, so you will do it. 1. 2, if there is a gunshot or a stabbing injury. And 3, if there is a clear indication that something is repairable. Otherwise, 9 out of 10 times, you will not operate on them. You will wait and see what recovers and then plan further surgery in the future. So the management of brachial plexus is not surgical.
So in case of gunshot injury, is it indicated to go for surgical? Because I've read somewhere in case of gunshot injury, the chances of recovery are very good. So we should follow wait and watch policy in that case.
Yeah, so in gunshot injury, there is not just the brachial plexus that is injured, but there are other injuries, especially vascular injuries. So if you're exploring the vessels and it is a gunshot injury, then you may actually do the nerve at the same time. And you're right, the recovery rate for gunshot is not actually very good. It is very poor because in a gunshot injury, there is a lot of other things happening, not just the penetrating injury, but there is a wave of forces of gases that goes in that creates a vacuum, and they may cause a lot more injury than you imagine. And sometimes most of the nerves are missing. However, the main management of brachial plexus is to wait and see. And to see when it's established itself, it demarcates itself, you can identify what part is missing and then see what is available and you can replace it. So
what is the exact duration of time we can wait and watch? Because after
when,
some duration of time, the muscle will go atrophy.
You cannot wait for atrophy. Atrophy takes 2 years. So that's a long time. So the minimum wait you can do is when you can pick a nerve conduction study and find changes. When does a nerve conduction study show you changes?
6 weeks.
So minimum of 6 weeks, possible 12 weeks. So you can wait up to 12 weeks and then quantify what your problem is. Once you know what your problem is, then you can sort it out.
So I think this is what I have read somewhere. That is a intervention. At least here.
I can't hear you, sorry.
6 weeks is for nerve conduction studies.
Yeah, 6 weeks is for nerve conduction study. You have to wait to quantify what your problem is. You can't go blindly to fix a brachial plexus injury when you don't know what you're looking for. So you want to make sure that you have an established reason. So when you have a nerve conduction study, which means that the nerve is trying to show something, it is regenerating or it's not doing anything, so that's the time you want to assess it. Now, if it's not doing anything at 12 weeks, then obviously you have to plan something for it. But if you can do a nerve conduction study and it shows that it is progressing, it is getting better, you have a migrating tunnel, then you don't have to operate. You can wait and see what's happening.
Fine, sir.
Okay, so I'm not a brachial plexus surgeon, but I have done the exam a long time ago, and this is what we were taught as trainees, that when somebody shows you a brachial plexus, don't talk about surgery, don't talk about what is wrong with the patient. First of all, is you have to say that this is a brachial plexus injury, and this is an open or a closed injury. When it's a closed injury, you tell them where it is. It's a pre-ganglionic or a post-ganglionic injury. And if it's a post-ganglionic injury, whether it's at the cords or at the medial, lateral, or posterior cord, or whether it's higher up than that, or whether it's individually at a different nerve level. And if you do that, your time with the examiner is about 10 minutes, 8 minutes. By that stage, you have done your time and you've done a very good short or long case. Okay, then talk about its surgery. When you tell them that I will wait initially, unless it's an open injury and I have to explore, I will wait for the injury to tell me where it is. And once I know what it is, then I will find out what I have accessory, what I can use and what I can transfer. And my aim is to 1, flex the elbow, 2, abduct the shoulder, and 3, get sensation. Now, if you get to that discussion, you have passed that table. Okay, you don't have to be clever to know everything about brachial plexus. This is enough for you to show that you're clever and you can pass that particular table. Yes, no?
Yes,
Yes.
sir.
Yes, sir.
Okay, so are we clear on brachial plexus? If you get a brachial plexus patient, you will be able to survive.
Yes, sir. Inshallah.
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 Okay, the second thing is, you know, if you see an instability or a dislocation patient, you will be able to survive. You will know what to do, what is the recurrence chance, what surgical options are available, how would you know what surgery to do for what patient, and what is the incidence of recurrence in these patients, what are the types of laxity, whether they're tubs or embry, and what surgical options are available to you. You will be able to discuss that? Yes?
Yes.
Yes, sir.
Okay, so I was planning to do gait tomorrow. Is that okay? Should we do gait?
Sure, sir.
Yes, sir. Yes, sir.
Okay, you
Yes,
guys
sir.
need to be a bit more active. You need to show your knowledge. You know, you're still slow in answering my questions. You know, you need to, I mean, exam is all about showing what you know rather than assuming the examiners know what you know.
Yes, sir.
Yes, sir.
Okay, so we stop this today
Sir,
and we'll come back hopefully tomorrow. Unless anybody's got a question, we come back tomorrow and we'll do gait.
sir, एक request है. The presentation that you were showing seems to be very good and comprehensive and stepwise.
On what?
For the brachial plexus that you
I'll
were.
put it on the forum. I'll put it in.
Yeah, please, sir. It would be very helpful. Thank you, sir.
Okay. All right.
Thanks, sir.